for 5 minutes.
Thank you, Madam Chair. Thank you, Mr. Secretary, for coming to testify before us today. Nearly 3 months ago, I sent a letter to the Center for Medicare and Medicaid Services concerning your department's intent to impose a minimum staffing ratio on nursing homes in the coming months. This administration chooses not to cooperate with congressional communication. I'd like to take the opportunity to discuss that issue with you today. As you know, long-term care facilities are still recovering from the COVID-19 pandemic as they try to backfill open practitioner positions during a national workforce shortage. According to the Bureau of Labor Statistics, Indiana's long-term care facilities had over 46,000 practitioners in February of 2020. As of 2022, that number fell below 40,000. Now, just last week, I had constituents in my office explaining to me their concern on how this rule will hinder their ability to care for patients. Mr. Secretary, why am I still hearing from providers that HHS and CMS are unwilling to consider and discuss their concerns?
Congresswoman, please, if there are particular providers that believe that we, HHS and CMS, have not been willing to speak to them, please let me know who they are, because we have reached out to providers throughout the country to talk about the staffing levels of nursing homes. And,
okay, we will do that. If this rule is to be introduced, the providers in my district have made it clear that long-term and post-acute nursing care facilities will be unable to provide continued care in rural areas such as the district that I serve, and that's quite frankly unacceptable. It will push patients to unnecessarily higher levels of care, costing already high-cost programs, driving those costs even higher, not to mention the fact that the higher levels of care are not always optimal for these patients. Instead of implementing a top-down rule that will force providers to increase their staffing minimums, I encourage your department to take time to meet with these providers and consider how we can best support their success, particularly as they're still recovering from the pandemic. I'd like to discuss another example, moving on, where your department is, in my view, just not listening to the providers. Of more than 6.7 million patients with Alzheimer's across the country, more than 110,000 of them are Hoosiers. As you know, the FDA has approved monoclonal antibody treatment created in Indiana that has demonstrated it can slow down Alzheimer's for individuals with mild cognitive impairment. Medicare has traditionally covered all FDA-approved drugs, yet it has continuously chosen to not allow for unencumbered access to Alzheimer's treatment. Why is this, Mr. Secretary?
Congresswoman, I've tried many times to explain this because I myself, my wife, we've all gone through this. I suspect maybe you have as well, where someone in your family may have been afflicted by Alzheimer's or some other form of dementia. It is very difficult. And I appreciate and applaud all those people who are trying to push as aggressively as possible to get the kind of care that would help their family members get better. But where I think I have to try to explain is constantly is that once the Federal Food and Drug Administration takes action and says a particular medicine can be put out for consumption because it will be safe and effective, the decision then becomes on the Medicare side whether or not that drug will be listed as part of the medicine.
So what is the answer? Why is that not available to those patients?
Because the standards are different between what the Food and Drug Administration uses to determine to put out a drug and what CMS determines whether or not to include it within Medicare.
Why is that?
Because by law, Congress passed a statute that says FDA treats its work with a different standard than CMS. So because FDA has done its work doesn't mean that CMS automatically then takes what FDA did and uses it for Medicare.
Those living in rural districts such as mine are more likely to be affected by this if the CMS policy for coverage with evidence development moves forward. The logistical challenges for patients and caregivers alike, as well as healthcare providers in these rural areas, it will make it increasingly challenging to meet the needs of those patients. Are you willing to consider that CMS could reevaluate the current policy of requiring coverage with evidence development for this class of therapeutics?
CMS, as we're speaking, is doing an ongoing reevaluation because once the information that they get is sufficient for them to say, we now have passed the bar to include that drug within coverage within Medicare, they will announce that. So it's an ongoing process within CMS.
I urge you to allow for the immediate access to FDA-approved treatments for patients that would benefit from these important therapeutics, just as it does for all other classes of FDA-approved medicines. I won't stop advocating for improved health care in rural areas. I worry that continued suboptimal performance will continue if HHS leadership does not make meaningful changes to those affected in rural districts. Madam Chairman, I yield back.